Ladies and gentlemen, so I'm Dr. Lin Yan Zhang from Taipei, Taiwan. Today my topic is how to assess the risk for ventricular tachyarrhythmia. This is my disclosure. As we know, patients with ventricular arrhythmia are at risk for sudden cardiac death. We may need the right tool to assess the risk and predict the future outcome. Recently, the important International Heart Rhythm Society set up the consensus document and tried to summarize the recommendation with regard to the risk assessment of cardiac arrhythmia. The objective of this consensus document is to provide the evidence-based risk assessment and have the improvement of the patient care in patients with the VT. So, what is the general tool for risk assessment in patients with the VT? Currently, we can use the ECG and the Holter wearable device. And we can use the imaging studies such as echo, MRI, genetics testing, and program ventricular stimulation. All of these tools are useful to identify the risk for the sudden cardiac death. I'll give a short introduction of each one. First, all of the ECG, 12-lead ECG is the most important tool. The 12-lead ECG provides diagnostic and prognostic information in patients with inherited high-risk syndrome, including the long QT, short QT, Brugada, and Arvc. Exercise ECG provides the diagnostic and prognostic information for patients with long QT, ACM, hypertrophic cardiomyopathy, catecholamine-dependent polymorphic VT. These arrhythmia were related to the exercise and exertion, and the exercise ECG should be obtained. Among the predictors shown to have value, these factors are the QRS widening, fractionation, QT prolongation, T-wave alternance, and ventricular ectopy. This prognostic value can be associated with additional imaging, genetic testing, and contribute to the effective risk stratification of this patient. Second, the imaging modality. So, the left ventricular ejection fraction remains to be the key independent factor for risk stratification for sudden cardiac death. And this is very important as to guide the implementation of the ICD. Cardiac MRI with a late gargling can be provide important prognostic information and may allow us to accurate assessment of the scar. And the presence and the location of the scar can portend a higher risk of sustained VT. Third, the tissue and the genetic. Tissue diagnosis can be beneficial to differentiate various infiltrative cardiomyopathy that can contribute to the risk for arrhythmia events. And genetics testing should be considered in several inherited arrhythmia disease associated with the increased risk of ventricular arrhythmia and sudden cardiac death. Last, the invasive electrophysiology study. The EPS is indicated in patients with syncope and previous myocardial infarction or other type of scar-related condition. When syncope remains unexplained after other type of non-invasive evaluation, the EPS may be considered in patients with reduced ejection fraction without a primary ICD indication, and also in patients with non-sustained VT to ascertain the presence of sustained VT events. However, the EPS invasive procedure is not recommended for some disease such as the long QT, short QT, catecholamine VT, and or the early reparation. Also, EPS is not recommended for risk stratification in patients with ischemic or non-ischemic cardiomyopathy who already meets the criteria for ICD implantation. For individual disease, how to assess the risk of ventricular arrhythmia in specific population. So I'll give the introduction in detail. First, in patients with ischemic cardiomyopathy, the most important factor are the presence of ventricular arrhythmia and the reduced ejection fraction. This is the most important. Also, ejection fraction is the most proven image modality in prediction of sudden cardiac death. However, in patients already have ICD therapy, only 1 or 5% have appropriate ICD therapy. For the majority of the patients who receive ICD will not have ICD therapy over a long-term period after implantation. It could be possible that more than 70% of the sudden cardiac deaths in the community occur in patients with a preserved ejection fraction. Therefore, we have to assess the substrate and ischemic events of the Vdmvf need to be assessed appropriately, including a corneal angel, nuclear scan, stress echo, or MRI. MRI is very important. It can be considered to evaluate the arrhythmia substrate, including the scarring to include in the risk assessment, and also to guide the VT operation. This investigation should be preferentially performed before ICD implantation to avoid the artifact due to the presence of the implanted device. In patients with a reduced ejection fraction of ischemic cardiomyopathy, what is the suggestion for primary prevention of Vdmvf? So we have to consider the substrate and the ischemic events. And also the cardiac MRI is very important. And in patients with ejection fraction of larger than 35, what is the indication for primary prevention of Vdmvf? As ischemic cardiomyopathy, substrate ischemic event, we need to appropriate evaluate it. We may use the EPS to induce if there is a sustained VT, and which can be considered to improve the Vdmvf risk stratification in patients with a preserved LVEF, especially in patients in the covalence phase after 2 months after an acute coronary syndrome. So this slide shows you the risk of MRI delay enhancement and the role of EPS in patients with different ejection fraction value. So as you see from the left panel, so in patients with a preserved EF or reduced EF, all of these patients, the presence of the delay enhancement of the MRI predict the worst long-term outcome. Right panel, it shows you that even from the MUSTD trial, in patients with reduced ejection fraction, the positive inducibility of the VT correlate with the worst long-term outcome. Second, in patients with a non-ischemic cardiomyopathy, MRI may be considered for the risk stratification of the sudden cardiac death. EPS could be considered for risk stratification of the sudden cardiac death in selected patients with a non-ischemic cardiomyopathy who did not meet the criteria for ICD implantation. So this slide shows you the presence of the LGE of the cardiac MR, which predict the adverse cardiovascular events, including the all-cause mortality, heart failure hospitalization, and also the sudden cardiac death. How about the patient with inflammatory cardiomyopathy as a type of non-ischemic events? So we can use the cardiac MR or PET scan to delineate the etiology of the non-ischemic cardiomyopathy, initiate the etiology-driven treatment, and to evaluate the prognosis. This is a patient with myocarditis. So using the cardiac MR, we may identify the delay enhancement of the lateral wall of the left ventricle. The presence of LGE predict the worst long-term outcome in terms of the survival. Therefore, in this patient, the presence of LG from cardiac MR and worse ejection fraction of less than 40 correlate with the major cardiovascular event and future mortality. In patients with congenital heart disease, how to assess the risk for ventricular arrhythmia? In the pediatric patient, the presence of the ventricular overload, surgical scar, or ventricular dysfunction, and the previous conduction defect are recognized as risk factor for VT. In the adult patient, the old age and the surgery, poor hemodynamic status, and prolonged QRS from ECG are the common risk factor for ventricular arrhythmia. So in adult patient, the VT will mainly observed after correction for tachyarrhythmia follow and the left ventricular outflow check defect. So in patients with a tachyarrhythmia follow, the residual hemodynamic lesion and ventricular dysfunction were the most important risk factor for ventricular arrhythmia and sudden cardiac death. Therefore, the frequent VPC and the QRS prolongation and palliative systemic to pulmonary trunk, syncope, atrial tachycardia. This factor were also the risk factor for the sustained VT. So this slide shows you the value of program ventricular stimulation after tetralogy follow correction. So patient with inducible monomorphic VT or polymorphic VT, this is correlated with the long-term free survival of the VT and starting cardiac death. So how about the risk for ventricular arrhythmia in patients with inherited arrhythmia syndrome? In patients with the primary inherited arrhythmia syndrome and cardiomyopathy, should undergo risk stratification that integrates the clinical presentation, family history, and many types of non-invasive diagnosis tests. Selected patients with primary inherited arrhythmia syndrome and cardiomyopathy may benefit from electrophysiology testing to refine the non-invasive risk stratification. For example, in patients with Brugada, there is untested agreement that the symptomatic patient, that is a syncope or cardiac arrest, are the high risk of sudden cardiac death, require the aggressive therapy with the ICD in most of the clinical scenario. ECG, including the QRS fractionation, early deprivation, and Brugada type change from the precordial lead to the other non-anterior precordial lead, and also the positive SECG. These are very important factors for the ventricular arrhythmia. Also, the presence of SCN5A mutation also contribute to a risk in patients with Brugada. So there is a score model in patients with Brugada to predict the risk of mortality events. So this risk factor, including the spontaneous type 1, Brugada's ECG, early familial sudden cardiac death, inducible EPS, or syncope, a genetic defect, and sudden cardiac death. If you have a more point of the risk factor correlates with worse long-term outcome, they can be assessed the future risk of an event in patients with Brugada. How about the long QT and the CPVT? In patients with long QT, the clear defined disease-specific risk factor are the resting QT prolongation and also documented the arrhythmia and also genetic mutation. In patients with CPVT, the response of arrhythmia to the exercise predict the events, including the breakthrough symptom of the therapy. Similar to the long QT1, the CPVT due to RLR2 mutation also have some degree of the risk depending on where the renin receptor is the mutation fails. In patients with hypertrophic cardiomyopathy, the most important factor is septal thickness. This is a hallmark of the disease as an important contributor to a risk. So other risk factors including the left atrial diameter, outflow tract gradient, ventricular arrhythmia, symptom as syncope, and the demographic factors such as age and family history. These are also potential risk factors for patients with hypertrophic cardiomyopathy. Last, I'd like to tell about the risk stratification in patients with ARVC. In patients with ARVC, the history of aborted sudden cardiac death, documented sustained VT, severe RV dysfunction, identify the risk of sudden cardiac death. So we know that in patients with ARVC, we should have advice not to perform the high level or endurance exercise. This is a modifiable risk factor to predict a sudden cardiac death. Other clinical factors such as age, male sex, unexperienced syncope, non-sustained VT, and also the number of anterior precordial lead with T-wave inversion and genetic mutation, that can be also the risk used to predict the patient of ARVC at the risk of sudden cardiac death. In patients with a confirmed ARVC, we should have recommended the regular Holter monitoring or imaging for assessment of the ventricular function. That will be quite useful. A detailed exercise, a history of exercise intensity and duration may be helpful in ARVC, as exercise level could be a modified risk factor for adverse cardiovascular event and disease progression. So also, there's a ARVC score to predict the risk of AVT. So according to the model of the including the factor of sex, age, syncope, not sustained VT, VPC number, the T-wave inversion number, right ventricular ejection fraction, and have a model for 5 years risk stratification. So this is a 5-year the risk score is currently the most significant predictor for the events. However, based on the MRI, also have provide some additional prognosis value. The risk of left ventricular involvement could be underestimated. With the MRI study, the overall risk for LV involvement for Arvc phenotype is 27%. So the patient with a biventricular involvement or left ventricular involvement have even a higher risk of mortality event as compared to long RV involvement or negative cardiac MR. I think this is a relatively important prognosis additional information for cardiac MR. So ladies and gentlemen, this is my summary of my slide, my conclusion. So the presence of ventricular arrhythmia events are related to the risk of sudden cardiac death in structural heart disease and reduced ejection fraction as a surrogate marker. Imaging study as cardiac MR with late ganglion enhancement is quite useful and can be considered to evaluate the arrhythmia substrate and to guide the VT ablation procedure. EP study may be considered for risk stratification of sudden cardiac death in select patients with non-ischemic cardiomyopathy who did not require the indication for ICD implantation. Thank you.